In this lecture, we're going to tackle both the septic joint and crystal disease. They both present as a monoarticular arthropathy, red, hot, swollen, tender, acute, and toxic. So let's start off with a diagnostic tree. We know the patient is going to have a monoarticular arthropathy. And it's red, hot, swollen, tender, looks toxic, so we know to get the arthrocentesis. There's going to be two arms here. It's going to be the crystal disease and septic disease. So let's start off with the crystals first. Now, since we're talking about crystal disease, not surprisingly, on the arthrocentesis, you're going to see crystals. And because it's crystal disease, you're probably not going to see any bugs. The gram stain is negative. And crystal disease is usually going to be inflammatory joints, so less than 50,000 white blood cells on that tap. And then once you get down to crystals, there's really only two diseases to consider: gout and pseudogout. Pseudogout is easier, so let's tackle that one first. Pseudogout is going to present as positively birefringent crystals that are rhomboid shaped, caused by calcium pyrophosphate. If you see a histology slide and there's a bunch of pink or purple squares, pseudogout. And the only thing you need to know is that it's calcium pyrophosphate. It's usually associated with some other chronic metabolic condition that's leading to this, and you treat the pseudogout by treating the underlying condition, blah, blah, blah. If you see pseudogout, treat the flare. The flare is going to be treated by colchicine, NSAIDs, or steroids. And really they are equivocal to each other. But as I've taught you in this series already, get people off steroids. So steroids should be your last choice. NSAIDs can be first unless there's chronic kidney disease, then there's colchicine. Colchicine causes diarrhea, and so is dose limited by the diarrhea. So pick based on the comorbid condition. That's pseudogout. Gout's a lot harder, so let's spend a little bit more time on that. For gout, still going to be positive crystals. What you're going to see is negatively birefringent crystals that are needle-shaped. This is caused by monosodium urate, and it's the uric acid that's the problem. If you see histology slide and there's a bunch of little yellow lasers going all over the place, gout. And gout comes down to two things. It is either decreased elimination of uric acid, or it's increased production. And this distinction really doesn't matter anymore, but if the test goes way out of its way to say this person is truly an underexcreter, that is, they have a perfect diet, they have got the 24-hour urine uric acid test, they're definitely an underexcreter, and you should not treat this person like normal gout. If they go way out of their way, the answer is probenecid. This is not the case for 90% of the people. So let's talk about the gout you're going to see. Well, first, I want to talk about uric acid and renal failure. If you increase the production substantially, say in tumor lysis syndrome, you can lead to renal failure by just dumping uric acid into the bloodstream. That happens when you give chemotherapy for tumors with big cell burdens, like leukemia or lymphoma. What will happen is the patient will be sent into renal failure. I know this has nothing to do with gout, but we're talking about uric acid. So tumor lysis syndrome can be caused by leukemia, lymphoma, getting chemo, leading to renal failure. What you want to do is prophylax the patient. Give them intravenous fluid so that anything that's produced is peed out. You keep the urine dilute and keep them urinating to get rid of all that excess uric acid. And you prevent the production of more uric acid allopurinol. More on that later. But if they fail to respond to your prophylaxis, or you just forget, and you diagnose tumor lysis syndrome, go ahead and give them respiricase. Don't learn the mechanism of action or how it works, just know that if you have tumor lysis syndrome, give respiricase. Okay, that's not going to be in the 90% either. So what's gout normally look like? Well, the person is going to have either CKD, drink alcohol, or be on a thiazide diuretic. And then this person comes in with podagra, the red hot swollen great toe. That's gout. And gout usually happens. They have the predisposition to get gout. They bump a joint. The next day, red hot swollen tender, can't move it. They look very toxic. So you've got the arthrocentesis that shows the crystals. And that's really how you're going to end up with a diagnosis of gout. And very much like pseudogout, you're going to want to treat the acute flare. And this should sound similar. Colchicine, NSAIDs, steroids. But after that flare is over, you want to try to get them to not have flare-ups in the future. And the way you do that is by reducing their uric acid. The things that cause an elevated uric acid that you can impact with lifestyle are alcohol, red meat, and fructose. Red meat includes seafood. Decrease alcohol, decrease ingestion of red meat and seafood, and decrease the ingestion of fructose, and you're actually going to improve the uric acid naturally. You could also change the BP med to, say, a calcium channel blocker or an ACE-ARB instead of using the hydrochlorothiazide. That's all well and good. All right, but then what else do you need to do if someone's coming in with repeated attacks? One gouty flare is not a big deal. You just treat it and see if you can not make it happen again. But if it keeps happening, then you need to do a little bit more workup. The diagnostic step here is the uric acid. Now notice where the uric acid is coming into play. It is coming into play well after the flare, well after lifestyle intervention has been made. You do not screen for gout or the predisposition for gout by getting a uric acid without symptoms. You don't get a uric acid during an acute flare. It won't do anything. You get the uric acid when you've committed the person to ongoing chronic therapy. Get a uric acid. It's diagnostic if it's greater than 6. Generally, 6.8 is the actual cutoff for which the risk increases. But your goal is to get their uric acid less than 6. How do you do that? Well, lifestyle modifications is ideal. So the first treatment is lifestyle. But if they've had more than 2 attacks in a year, you're going to use allopurinol. Allopurinol is the xanthine oxidase inhibitor. It reduces the production of uric acid. Febuxostat is the other one. Be careful with allopurinol. Don't start it in an acute flare. And if you start it, you might cause an acute flare. That's okay. If you have started it and they flare, continue it. Just treat them through it. Allopurinol or febuxostat are a way to reduce the uric acid. But you also want to prophylax them against having more gouty attacks. And you have the choice of colchicine, NSAIDs, or steroids. You're just going to use lower dose. Now, ideally, you would use colchicine. So if you asked a question about gout prophylaxis, pick colchicine. If you're asked a question about uric acid levels being reduced and reducing the number of attacks, allopurinol. If you have the option of lifestyle changes, what you should go for is red meat, seafood, beer, and sugar. And if you're in an acute flare, colchicine, NSAID, steroids based on a comorbid condition. A lot to know about gout. It's not that complicated, but you have to keep it straight. All right, let's go to the other arm. Back to that monoarticuloarthropathy, red hot swollen tender joint, we did the arthrocentesis, and we get greater than 50,000 cells, positive organisms, and no crystals. This is infection. And there are really 2 infections you need to consider. That is going to be non-gonorrhea, which means staph. And you give non-gonorrhea, the other one's probably going to be gonorrhea. Non-gonorrhea or staph can happen in a couple of ways. Direct inoculation, They've got a sword coming out of their knee. Yep, that knee's probably infected. Or hematogenous spread. And the people who are going to get hematogenous spread are going to be people who push staph into their own bloodstream. And those are going to be the intravenous drug users and people on hemodialysis. Intravenous drug abusers probably don't clean their skin as well as dialysis nurses do, but dialysis patients get their skin accessed 3 times a week. And so eventually, one time, they might introduce some bacteremia. The way you diagnose staph is going to be on the Gram stain. The Gram stain is going to be positive. It's going to be positive for gram-positive cocci and clusters. And the point being, you are going to see the staph. You don't have to wait for the culture. There's nothing special you need to do. If it's staph in a joint, you're going to see it. You're, of course, going to get the culture and sensitivities and treat accordingly. But the treatment, empirically, is going to be nafcillin, especially on your test, nafcillin for MSSA. In life, what you're going to see people do is choose either vancomycin or linezolid. And they're going to do that for MRSA. If they're really toxic, you should probably choose MRSA coverage. And the reason for that is, if you don't treat the infection well, they can lose their joint or lose the limb. MRSA has a high enough prevalence in the community where it's worth giving vancomycin or linezolid. But on the test, the incidence of staph septic joint is probably more likely to be MSSA, and they want you to choose cost-effective care. So in real life, you start vanc, get the culture, and then de-escalate if you find MSSA. On the test, choose nafcillin first, unless they give you really strong evidence that this is going to be MRSA. So it fell in a hospital or is somehow associated with healthcare. Now, that's a long-winded way of saying I don't know which one to pick, but if it's just all comers, nafcillin. If you have a risk factor for MRSA, vancomycin, de-escalate when the cultures come back. And lastly, if there's hardware, the hardware has to come out. Now, if we talk about gonorrhea, gonorrhea is essentially only hematogenous. And it occurs as an STD. So look for the person who has a history of HIV or syphilis. They may also have cervicitis or urethritis. This is caused by gonorrhea. Or look for the sex worker who doesn't use condoms. Some risk factor for STD. That's what you're looking for gonorrhea septic joint. And the problem is the diagnostic step is going to be tricky because the Gram stain is likely to be negative. And I don't mean it's Gram negative because it's gonorrhea. I mean it doesn't show anything. And that's because in order to really see it, you might have to get a chocolate agar. But that's not the best test. If you have to choose between them, choose the nucleic acid amplification test. That's going to be the best way to diagnose a septic joint with gonorrhea. It may be negative on Gram stain, but get the NAT. And because you haven't seen staph, and staph's definitely going to show up, you're going to treat it like gonorrhea. You give ceftriaxone. But this isn't the one-time dose for cervicitis. This is 7 to 14 days IV. And when you find gonorrhea, you treat chlamydia. When you find chlamydia, you treat gonorrhea. And to treat the chlamydia, you can use doxycycline or azithro. While there's debate on this, you should not be asked to choose between them. It's going to be ceftriaxone IV for 7 to 14 days for the gonorrhea in the joint, and then doxy or azithro for the chlamydia. All right, let's clip through this really quickly one time. You tap the joint. If there are crystals, it's a crystal disease. Positive birefringent rhomboids, pseudogout, negatively birefringent, needle-shaped crystals, gout. You're going to treat them the same for the flare, colchicine, NSAID, steroids based on their comorbid conditions. For gout, get the uric acid down using lifestyle allopurinol, prophylax using colchicine. If instead you saw bugs and no crystals, if you actually saw gram-positive cocci and clusters, pick nafcillin unless they give you risk factors for MRSA, then it's vanc. If you're definitely an infectious arthritis, but you don't see anything on Gram stain, it's gonorrhea, get the nucleic acid amplification test, and treat with ceftriaxone, 7 to 14 days IV, and doxy or azithro. If ever you have a septic joint and there's hardware, the hardware needs to be removed. That's monoarticular arthropathy.